Assalamu alaikum wa rahmatullah. Welcome, dear student. In this lecture we will discuss a great gland in our body, which is pituitary gland, and our topic is for hypopituitarism. Initially we will discuss pituitary gland physiology, regulation of its function, and then we will proceed to the main objective, which is hypopituitarism. Anatomy of pituitary gland. Pituitary gland has another name, which is hypophysis. Why this term? Because pituitary gland is located below the brain. It is the lowermost structure of the brain. Anatomically, it's located just below the hypothalamus, here in green color, and it's connected to the hypothalamus by what we call the pituitary stalk or pituitary neck, a band connecting hypothalamus to pituitary gland to be functionally regulated by hypothalamus. According to the size of pituitary gland, we have here many sizes. To imagine the size of pituitary gland, it's a pea size, which is the first vegetable piece here. It's just a 1 centimeter diameter and 0.5 gram in weight. It's a very, very delicate structure, small structure that can be easily injured. And because of its important function, the pituitary gland is protected by a bony depression at the base of the skull. It's called pituitary fossa or sella turcica. It looks like the Turkish saddle, as the figure shown. During discussing the anatomy of pituitary gland, we have an important term called diaphragma cell. Diaphragma cell is the roof of pituitary fossa. It's formed of dural matter. Dural matter form a fold to cover the roof of pituitary fossa. This roof is not completed, it's partial, because it has a central opening that allows the passage of pituitary stalk and passage of the blood vessel connecting hypothalamus with pituitary gland. The importance of this dural fold is to restrict and prevent the presence of CSF in pituitary fossa. So pituitary fossa is a CSF-free structure. Now we will discuss the function of pituitary gland. Functionally, pituitary gland is divided into two lobes. We have anterior lobe and posterior lobe. Anterior lobe is called adenohypophysis, which means by adeno it's endocrinal gland. So anterior lobe is a true endocrinal gland. It's called another name, the master or the maestro of endocrinal gland orchestra, as we have in our BBL case. So we can call the maestro of endocrinal gland orchestra, which is pituitary gland. It's a term given for anterior lobe only, which is adenohypophysis. It's a true gland. While posterior lobe is called the neurohypophysis. Neuro means have a neurological function. So it's not a true gland, and now we will discuss how it's not a true gland. For pituitary hormones secreted from anterior lobe and posterior lobe, we have many hormones that makes pituitary gland is very important in our life. You have to know which hormones arise from anterior lobe, which hormones arise from posterior lobe, and don't be confused together. For anterior lobe, we have many hormones. We have growth hormone, we have thyroid stimulating hormones, we have adrenocorticotropic hormone, which is ACTH, and we have gonadotropins, which are FSH, follicular stimulating hormone, LH, luteinizing hormone, and we have the hormone of prolactin. While posterior pituitary secreting only two hormones, which are arginine vasopressin. Another name is ADH, as you know, it's antidiuretic hormone, and another hormone is called oxytocin. Anterior lobe, which is adenohypophysis, again it's the master gland in our body, or maestro gland of endocrinal orchestra, secreting many hormones that control the other glands in our body. What are the endocrinal gland escaping pituitary control? We said before that we have growth hormone, we have TSH controlling thyroid gland, we have ACTH controlling adrenal cortex, and we have gonadotropins controlling gonads, either ovaries or testes. So we have another endocrinal gland that escape pituitary control. We have 3 important glands, and all endocrinal gland which escape pituitary regulatory effect are starting by letter B to be easy for you to remember them. We have the pancreas, we have parathyroid gland, and we have parafollicular cells of thyroid gland secreting calcitonin, and sometimes we added adrenal medulla, but usually adrenal medulla is considered as a part of sympathetic nervous system, not an endocrinal gland, and its secretion are mainly neurotransmitters, not mainly hormones, which are epinephrine and norepinephrine. Now we will discuss regulation of pituitary function. The control of pituitary function is mainly through hypothalamic control, and another modality for controlling pituitary gland function is negative feedback mechanisms. As we see in this figure, we have here the anterior pituitary gland, which is called the adenohypophysis. If you remember, we said it's a true endocrinal gland. Why it's true endocrinal gland? Because it contains the cells which are responsible for sensitizing, storage, and release of the anterior pituitary hormones. The main regulation of anterior pituitary is through vascular connection between hypothalamus and anterior pituitary. This vascular connection is named as hypothalamo-hypophyseal portal circulation. It's very easy. Hypothalamo because it's arising from hypothalamus. Hypophyseal, which is another name of pituitary, portal circulation. So the connection between hypothalamus and anterior pituitary is a vascular connection, and this vascular connection is passing with pituitary stalk through the central opening of diaphragma cella. If you remember, it's a partial roof of pituitary fossa. Why this blood vessel connection is very important? Because hypothalamus secreting some hormones, either releasing hormone or inhibiting hormones that may stimulate or inhibit pituitary hormones secretion. For example, we have corticotropin releasing hormone. From its name, it stimulates the secretion of ACTH from anterior pituitary. We have another one, which is thyrotropin releasing hormone. Again, it stimulates the secretion of TSH and the prolactin hormones from anterior pituitary. Growth hormone releasing hormone, it stimulates the secretion of growth hormone from anterior pituitary. While we have another opposing hormone, which is called the growth hormone release inhibiting hormone. The another name is somatostatin, which inhibits the secretion of growth hormone from anterior pituitary. For gonadotropin, we have gonadotropin releasing hormone, which stimulates the secretion of LH and FSH. And for prolactin, we have 2 opposing hormone, either prolactin releasing hormone to stimulate prolactin secretion, or prolactin inhibiting hormone to inhibit prolactin secretion. All these hormones are hypothalamic hormones secreted to regulate the secretion of pituitary gland. This is another figure that shows that we have here in yellow colors, these are the nervous system in hypothalamus or nerve cells that secrete some granules or hormones, as you see, which is in purple in color, that reached the hypothalamic side of hypothalamo-pituitary portal circulation goes down through this vascular connection and reaching anterior pituitary to control the function and secretion of anterior pituitary hormones. Again, I stressed on that the vascular connection between anterior pituitary and hypothalamus is a vascular connection called hypophyseal portal circulation. To discuss the posterior pituitary, we call it neurohypophysis because it's not a true gland. Why it's not a true gland? Because it doesn't contain the cells that are responsible for sensitizing, storage, and release of the posterior pituitary hormones. We have two hormones, as we said, antidiuretic hormone and the oxytocin hormone. So why it's not a true gland? From which these hormones arise? Back to physiology, if you remember, this figure shows the nerve cells, which have two main parts: the body of nerve cells, which contain the nucleus, dendrites, and so on, cytoplasm and cell membrane, and we have another part which is the axon, that ended by what we call nerve endings. Here the connection between hypothalamus and posterior pituitary is a neuro connection, neurological connection or nervous connection, where the cell bodies of these nervous or nerve cells is present and located in hypothalamus. The axon of these nerve cells passing through the central opening of diaphragma cella. The nerve endings are the main bulk which forming posterior pituitary gland. So posterior pituitary gland is just a nerve endings for nerve cells arising from hypothalamus. What happens? The hormones are sensitized and will form it in the nerve cell bodies, then passing through the axons, along the axons, through pituitary stalk, reaching the nerve terminals present in posterior pituitary. So posterior pituitary is just a storage area for the hormones that was sensitized and released from nerve cells present in hypothalamus. So this is why we call the posterior pituitary as neurohypophysis, and it's not a true gland. Okay. This figure, another figure that clarifies the connection between hypothalamus and posterior pituitary. As we said, it's a neurological connection. The nerve cell bodies present in hypothalamus, which is responsible for sensitizing the antidiuretic hormones and oxytocin hormone. These hormones pass along the axon through pituitary stalk and ended in nerve terminal endings in posterior pituitary to be stored there. And again, this is why posterior pituitary is not a true gland and it's called neurohypophysis. At time we need these hormones, hypothalamus nerve cells are stimulated, release of nerve impulse as an action potential, passing through the axon, reaching nerve terminals to fire the secretion of these hormones, which are oxytocin and antidiuretic hormone. This is another figure but combining both anterior pituitary and posterior pituitary, where it's very clear now for you that the connection between hypothalamus and anterior pituitary is vascular connection, hypothalamo-hypophyseal portal circulation, while connection between hypothalamus and posterior pituitary is a nervous connection. Okay. The another point for regulation of pituitary gland function is the negative feedback or positive feedback mechanisms. Usually the pituitary gland function is under mainly the negative feedback and to some extent under positive feedback control. This figure shows for us the negative feedback inhibition controlling mechanism at the level of TSH, control secretion from anterior pituitary. As we see during stimulation of the hypothalamus by external stimuli, hypothalamus release TRH, which travels through hypophyseal portal circulation, reaching anterior pituitary, secreting TSH. TSH goes downward and controlling the thyroid gland secretion of thyrox T3 and T4. After T3 and T4 doing their function and the stress is subsided, started to do a negative feedback upon hypothalamus and upon pituitary, anterior pituitary lobe. This inhibitory effect will stop secretion of more TRH from hypothalamus and stop the secretion of more TSH from anterior pituitary, and the axis calm down again. This is another figure that shows negative feedback control of adrenal cortex function or cortisol secretion specifically. We have here non-specific stressful stimuli secreting or stimulating higher brain centers, stimulation of the hypothalamus, releasing CRH, corticotropin releasing hormone, goes down through hypophyseal portal circulation, stimulating anterior pituitary to secrete ACTH, goes down to adrenal cortex, stimulating cortisol secretion. After this stress is subsided, cortisol exerts a negative inhibition upon hypothalamus to stop more release of CRH, and negative inhibition upon anterior pituitary to stop more release of ACTH, and again the axis calm down. After finishing the physiology of pituitary gland, now we will discuss our main objective of this lecture, which is hypopituitarism. Now we will discuss hypopituitarism. As regarding the definition of hypopituitarism, it is a deficiency of one or more of pituitary hormones. So we have either isolated or combined pituitary hormone deficiency. Based on the level of the lesion, as we said, from physiology of pituitary gland and pituitary gland regulation of function, we have three items important for pituitary function: hypothalamus, pituitary stalk, and the pituitary gland itself. So any lesion at any of these levels can result in hypopituitarism. So the lesion will be on the level of hypothalamus, or pituitary stalk lesions, or anterior pituitary lobe defect, or posterior pituitary lobe defect, or both lobes defect. As regarding the etiology of hypopituitarism, we may have many reasons or causes underlying hypopituitarism. As you see, they all are starting by the letter I to be easy for you to remember. It could be idiopathic or inherited, either developmental defect in pituitary gland in form of aplasia, dysplasia, anencephaly, and midfacial defects, or genetic defects in form of either hormonal deficiencies resulted from defect of enzymes needed for synthesis of these hormones, or hormone receptor gene defects. The second possibility, it could be secondary to infection. One of most important infection in this area is TB, infarction, affecting the blood supply of pituitary gland, infiltration by abnormal metabolites or abnormal cells like sarcoidosis, hemochromatosis, invasion by tumor, either originated from pituitary tumor itself or originated from another CNS lesions and extend to pituitary fossa. Injury. One of most important causes of hypopituitarism is fractured base skull. As we known from anatomy of pituitary gland, pituitary fossa is present at base of the skull. Immunologic disorders, lymphocytic hypophysitis, where pituitary gland is infiltrated by abnormal lymphocytes, result from autoimmune mechanisms, or iatrogenic, like surgical injury of blood supply to pituitary, or injury of pituitary stalk during surgical maneuver, or radiotherapy in case of CNS tumors. We have this term, very important term called empty cell syndrome. Empty cell syndrome means that on MRI, it's an MRI term resulted from during MRI study of pituitary gland and pituitary fossa. We found that pituitary fossa is empty of pituitary imaging and it's replaced by CSF. So presence of CSF in sella turcica or pituitary fossa is called empty cell syndrome. What makes CSF invading pituitary fossa? In spite of we know from anatomy of pituitary gland, it's a structure free of CSF. The presence of CSF in pituitary could be related to primary defect in diaphragma cella. If you remember, diaphragma cella, it is the roof of pituitary fossa formed from a dural fold. Any defect in this diaphragma cella will allow herniation of a liquid membrane containing CSF into sella turcica. Gradually, sella turcica is filled with CSF, causing compression of pituitary gland against the wall of pituitary fossa. Atrophy of the gland and defect of function is resulted. Or it could be secondary. What I mean by secondary, that we have intact diaphragma cella, but the defect in pituitary gland itself. It is atrophied or shrinkage of pituitary gland itself that allow a space, empty space in pituitary fossa, encourage CSF to fill this empty space, causing more and more atrophy of the gland against the wall of pituitary fossa and defect of its function. The atrophied pituitary gland could be resulted from injury of its blood supply, surgical injury of pituitary gland, radiotherapy, or vascular defect as infarction of blood vessel supply to pituitary gland. So this figure shows how when CSF filled the pituitary fossa or sella turcica, compressing pituitary gland against the wall of pituitary fossa, causing atrophy of the gland and defect in its function and hormonal release. This is another figure where, as you see here, we have here a normal pituitary gland filling the pituitary fossa all over, and we have here the diaphragma cella, which is the dural fold present here, very intact and tightly connected to pituitary stalk to prevent any CSF herniation into sella turcica. On the second figure here, we have CSF started to herniate or present in sella turcica, causing compression of pituitary gland. Now pituitary gland is compressed against the wall of pituitary fossa, resulted in pituitary atrophy and defect in its hormonal. In this slide, we have here an MRI imaging for pituitary fossa and pituitary gland. Usually normal, we have here the pituitary imaging give a gray texture like the brain substance itself. Once you have a whitish texture here in pituitary fossa, like that present in fourth ventricle and third ventricle of the brain, this means that pituitary fossa is filled with CSF, and you can see that the diagnosis is empty cell syndrome. How to diagnose hypopituitarism? We depend on diagnosis for hypopituitarism on clinical diagnosis that resulted from a clinical picture of hormonal deficiencies according to the hormone deficiency present, and on laboratory diagnosis through hormonal assay. For clinical picture of hypopituitarism, we have endocrinal defect through a deficiency of these hormones resulted in a specific clinical picture related to the hormonal deficiency, either isolated or combined hormonal deficiency like deficiency of growth hormone, TSH, ACTH, LH and FSH, or deficiency of antidiuretic hormone. The another part of clinical manifestation related to the etiology causing hypopituitarism. As we regard, we have many causes like inherited, iatrogenic, surgical intervention, infection, and so on. Sometimes we have the mass effect causing increase in intracranial pressure, as we know all the manifestation of increase in intracranial pressure, or we may have a history of trauma, accidental trauma that resulted in base skull fracture. This base skull fracture usually as a target pituitary gland is one of the most important and delicate structure affected by skull base injury or fracture. Condition may be related to hypothalamic defect, and we know that hypothalamus defect resulted in sleep temperature, abnormal thirst sensation, and an appetite defect, or we may have mid-facial defect. One of most important causes of hypopituitarism or associated defect in pituitary gland is mid-facial defect, like cleft palate and cleft lip. And usually the most common hormones associated with this condition is growth hormone deficiency. Because pituitary gland is a midline structure, so any mid-facial defect could affect the pituitary gland, specifically growth hormone secreting cells. Now here we have some hormones of anterior pituitary effect or defective release and the clinical pictures related to these hormonal defects. You have already growth hormone deficiency manifestation in cases of short stature presented by growth retardation and tendency to have hypoglycemia. In case of ACTH deficiency, you will have Addison disease presented by weight loss, vomiting, hypotension, hypoglycemia, decreased skin pigmentation. You know that when you have a primary adrenal failure or primary Addisonian disease, ACTH usually increased, causing hyperpigmentation. But in case of hypopituitarism, the defect mainly is in pituitary gland, so we have defect in ACTH secretion. Now we will not having skin hyperpigmentation, instead we will have decreased skin pigmentation. TSH deficiency will be resulted in hypothyroidism, usually either congenital or acquired manifestation of hypothyroidism, and you know these manifestations in the separate lecture of hypothyroidism. Gonadotropin deficiencies resulted in either delayed puberty, as we know in the lecture of puberty, or made the child get into puberty and the injury happens after pubertal induction, but the child showing as a result of hypothyroidism arrested puberty. Prolactin release failure of lactation, and this is not of a matter or irrelevant in childhood ages, because lactation occurs in childhood bearing period in females, so prolactin deficiency doesn't have a specific clinical picture during childhood. Again, oxytocin, one of important hormones during uterine function during the labor and in milk ejection during the lactation, so again oxytocin is a deficiency is irrelevant in childhood period. Vasopressin deficiency resulted in diabetes insipidus, if you remember, and usually presented by intense thirst sensation and polyp. Again, this figure showed a manifestation of related to hypopituitarism according to a specific hormone deficiency, either isolated or combined, collectively as ACTH deficiency, TSH deficiency, LH and FSH deficiency, growth hormone deficiency, and ADH deficiency, and we revised all in the previous table. In this slide, we will discuss how to diagnose hypopituitarism based on laboratory investigation. Simply, we ask for hormonal assay to detect which hormones is deficient. But what is the difficult is the pulsatility or the pattern where hormones are secreted from the pituitary gland. Usually, most of hormones having what we call circadian rhythm. One of most important of these hormones is ACTH. ACTH is high in early morning, but reaching traces in serum by the evening. So when you wanted to discuss or to investigate for hypothalamo-pituitary adrenal axis, you should ask your investigation early morning before 9 a.m. This is number one. Another important maneuver during hormonal assay is what we call the dynamic tests or functional tests to diagnose where is the level of the lesion causing hypopituitarism. Suppose we have hypopituitarism related to TSH deficiency or low TSH level. Simply, we give the child TRH and assay the level of or response of TSH to this injected TRH. If we give a child TRH from outside, exogenous, and when we assay for TSH, we found TSH raised. So where is the lesion? All of us will be convinced that the lesion is hypothalamic because we give it the hypothalamic release from exogenous source, which is TRH, and the usual response appear in form of pituitary release of TSH. So the defect in hypothalamus and pituitary is good and well. Suppose you give TRH from outside but TSH not raised in response. So where is the lesion? The lesion should be in pituitary gland or TSH secreting cells in pituitary gland. The same if you use the CRH stimulation test to localize the lesion, whether is it hypothalamic or pituitary in case of cortisol deficiency. How to treat a case of hypopituitarism? Simply, we give a child hormonal replacement therapy according to the hormones defective in his body, based on diagnosis clinically and laboratory as previously discussed, and we should search for the etiology and manage this etiology. So the management here is divided into two parts. Management of the etiology causing hypopituitarism. Suppose you have a CNS tumor, you should deal with it either through radiotherapy or surgical excision and somewhat to relieve this defect of this tumor compressing pituitary gland or affecting its blood supply. On the other hand, you should revise the child hormonal level, and when you discover a hormonal defect, you just replace this deficient hormone. This table shows how to replace the hormonal deficiency will be. Suppose you have a TSH defect or release, so we give replacement therapy in form of L-thyroxine. If you have corticotropin deficiency, which is ACTH deficiency, we give cortisol in form of hydrocortisone therapy. LH deficiency and FSH deficiency, we give 6 steroids. In case of male, we give testosterone. In case of female, we give estrogen. And if we have defect in growth hormone release, we have growth hormone deficiency, we just give recombinant human growth hormone therapy. Now we will going to discuss posterior pituitary defect, and specifically we will concentrate on AVB, arginine vasopressin secretion defect, or antidiuretic hormone defect, because we all know that oxytocin is irrelevant during childhood period. Posterior pituitary gland or lobe, which is called the neurohypophysis, and we know why it's called like this, secreting two major hormones, which are vasopressin or ADH and oxytocin. We will concentrate on vasopressin and ADH because oxytocin is irrelevant during childhood. From the names of these hormones, vasopressin and ADH. Vasopressin, it's vasopressin. It's causing vasoconstriction of blood vessels to raise the blood pressure. While ADH, from its name, is antidiuretic hormone. It prevents diuresis, prevent water secretion through the kidney tubules to outside the body. Here we have ADH and AVP. The site of action of these hormones or this hormone are the terminal part of nephrons, which are distal convoluted tubule coming after the lobe of head, and the terminal part which is collecting duct. These are the common sites for action of antidiuretic hormones. The main action of these hormones or this hormone at this level is to prevent excess water secretion from the kidney or from the body through kidney tubules in form of urine. So it stimulates water, and only water, pure water, without any electrolytes, to be reabsorbed from the lumen of these distal part of nephrons, to be regained again to the serum to increase the blood volume. Once you increase blood volume, you increase blood pressure by both mechanisms. By increasing water reabsorption, increase the blood volume, And on the other hand, we do vasoconstriction of blood vessels, which is vasopressin, by vasopressin action, to raise the blood pressure. The net result of increased water reabsorption from renal tubules is that the urine volume will be decreased and the urine concentration will be high. So the end result is secretion of a low volume of highly concentrated urine. How AVP is stimulated? Either osmotic stimuli or hemodynamic stimuli. It is easily stimulated by any change in plasma osmolarity, because as we know, it's controlling water movement across renal tubules. So any change in the plasma osmolarity, either hypoosmolarity or excess osmolarity, hyperosmolar state, both will be stimulate AVP secretion or inhibit AVP secretion. On the other side, hemodynamic changes, rapid loss of blood volumes or change in blood pressure will be again stimulating AVP secretion. Suppose you have a child who is in shock, hypovolemic shock due to accident and loss of major blood volume during this accident. This decrease in blood volume followed by decreased the blood pressure because of lost blood will stimulate AVP secretion to do both vasoconstriction of blood vessels to raise blood pressure again and stimulate water reabsorption from renal tubules to increase blood volume again, aiming for maintaining effective plasma volume and pressure. This figure shows the effect of ADH when ADH is present on the figure on the left side, and if you have ADH absence on the figure of right side. Here, as you see, based on distal convoluted tubules and the collecting duct, ADH stimulating water and only water without any electrolytes to be reabsorbed from renal tubules in human to regain again into the serum. So the net result here, as you see, a very small amount of urine, of highly concentrated urine, because only electrolytes pass throughout the body with little amount of water. So the net result is highly concentrated, small volume. On the figure on right side, we have here ADH deficiency. Now we can't reabsorb water from distal part or terminal part of renal nephrons. So all water will be excreted through the renal tubules in form of urine. Now the net result is large amount of urine, and this urine usually is highly diluted because it contains many or much amount of free water. AVP deficiency or ADH deficiency. The name of this disease is central diabetes insipidus. Central diabetes insipidus. It's called diabetes because it's mimic the condition symptoms mimic the true diabetes mellitus disease. The diabetes insipidus is characterized by polyuria and polydipsia. The child usually void a large amount of urine and have intense thirst sensation by day and night, secondary to AVP deficiency. The defect either in hypothalamus, pituitary stalk, or pituitary lesion itself, because as we said before, the AVP is sensitized in the nerve cell bodies present in hypothalamus, passing through the axons which along pituitary stalk, reaching nerve terminals and posterior pituitary lobe. So any lesion at these three sites will result in AVP deficiency. What's the clinical picture and laboratory diagnosis? From previous discussion about the function of AVP, now we will have a child with polyuria, more than 4 liters per day. Urine is highly diluted, so urine is having low urine osmolarity. On the opposite side, we will have high serum osmolarity because all water or free water will pass through urine. High serum sodium as electrolytes. And to specifically diagnosing the AVP deficiency, we have a test of water deprivation test. Simply, we expose the child to be deprived from water under close medical supervision because sometimes the child may go into shock or hypovolemic shock. We all know that during water deprivation, the body deals with this water deprivation by trying to void or even not void any urine through the body to maintain the homeostasis. A child who have AVP deficiency, in spite of water to be water deprived, he again still passing a large amount of urine, and this large amount may expose the child to hypovolemic shock. This is why water deprivation test is done under close medical supervision. Or simply you ask for AVP test or hormonal assay for AVP, and you will find that AVP level in the serum is low. How to manage and treating diabetes insipidus? Number 1, adequate water replacement. Keep a child to drink water as he think he need, because he by himself or she by herself can tolerate and can maintain homeostasis of plasma osmolality by thirst mechanism. So adequate water replacement is essential to avoid metabolic complications. And we should replace, on the other side, we should replace the hormonal deficiency. We give a child synthetic ADH replacement therapy, and in form of either tablet or in form of nasal inhalation through nasal spray. This is our lecture about hypopituitarism, either related to anterior pituitary hormones deficiency or posterior pituitary hormone deficiency. I hope that all items are covered, and thank you.